said, I know of her work, and she is, a leading expert in DEI, and I'm sure all of you who have read her work know this. She's at UC San Diego. She has published quite a bit in this area, whether it be on implementation science frameworks, strategies, very familiar with REAIM and other frameworks. She is the co-director of UC San Diego's DEI Center, which is NIH funded. She's also lead the DEI core for the CFAR UC San Diego. She's oftentimes the go-to person by NIH. She has contributed to graduate degrees. She teaches courses in IS. So when you think of DEI and implementation science in particular, there's about 7 or 8 names that always come to me as the giants of implementation science, and she's definitely one of those. So welcome, so very nice to have you here.
Good morning, everyone. How are you all doing? This is very early morning for me. We are getting to my wake up time, 6:30, so that's good. I am from California, as Dr. Prado mentioned it. Thank you so much. And I wanted to thank everyone here who invited me to be here. I have been really enjoying my interactions with Dr. Kanamori's team. I have been working with them for several years now, and we developed a really cool collaboration where we really bidirectionally learn. I have learned so much from his team, and then I am hopeful that they have learned from us. And so we continue to look for opportunities to work together. And I'm excited to share some of the resources and ideas with you today about dissemination and implementation science theories, models, and frameworks. And then happy to discuss anything outside of this talk. Perhaps that's going to be more interesting. I will be here today and tomorrow, so anytime during those times, please come up to me, and happy to meet in addition to that official consultation time. And I would just say that I have really enjoyed my work in dissemination and implementation science because it expanded my knowledge around different topics and settings. And that's perhaps the most amazing beauty of this, that you use these methodologies across different settings and populations and topics, and you learn in each setting something different that you can translate to another setting. So I just wanted to highlight a few things that I heard in this presentation by Dr. Harkness, Dr. Prado, and Dr. Kanamori so far, because it's going to be really nice as we move into the D&I theories, models, and frameworks. First of all, how many of you would see themselves as kind of very, very new to D&I or implementation science? Okay, a number of you. Okay. The concepts that I would like to highlight, and they will come back throughout the week, and I was looking at the amazing agenda, by the way, I really regret to miss the rest of the days, are these notions of implementation science versus implementation, and the key difference between doing it and studying it. And I think they are interconnected, but there is a difference in how you ask questions. And so that's important to keep in mind. And when you think about theories, models, and frameworks, this is going to come up. Second, multi-level complex, contextually messy. Dr. Kanamori highlighted determinants. I think that at the end of the day, when I think about all the work I have done over the past couple of decades, determinants ruled. And so when context is coming in, it doesn't matter whether you have proven that something worked in a context, it can completely go away. Or something that doesn't fit and worked elsewhere will not work in your new context. And so the importance of equitable implementation science is just, I cannot emphasize it enough. Implementation science itself is topic agnostic. You can apply it to good and bad ideas. Brian Weiner said this in a very neat Twitter post. And so I think about that a lot, that we can do more harm. We can be really purposeful in creating you can use the methodology very, very purposefully and vehemently and improve implementation of things that should not be implemented. And so I think that that's where, for me, if I'm going to put this up on that post-it, the difference is that you care about the impact. You care about whether you are going to do something good, and you are not forcing certain interventions, even though they might be deemed evidence-based interventions in context when they will not work. much of our evidence-based interventions, unfortunately, and I'm going to say something that perhaps is not going to be very politically appropriate, were created in very highly controlled settings and not tested with people who are most in need for help. And then we expect them to work in low resource settings with individuals who have complex lives. And so that's my main concern. And so we talked about this kind of pipeline that was shown, and sometimes we need to skip the pipeline and we cannot go linearly. We need to do it in a way that we think about the end game. And so that hasn't happened too often, and the funding is not always present for us to do it that way. So those are some general ideas. And then the implementation research logic model will come up throughout the week. Thursday, there will be an intense session with J.D. Smith, who developed this with other colleagues. But I will bring it up as well, because I think that that's a great opportunity to make implementation science more accessible to your partners. And so we will talk about that. So I will stop with kind of the summary, and I will mention two ideas that I didn't include explicitly in my slides, but I regret it. And I don't want to forget them. So first of all, when we talk about theories, models, and frameworks, and anything implementation science, this should not be an impediment to your work. Often what I see, people become extremely academic, which is exactly the contrary what we are trying to do in implementation science. And things get too complex, and we are not doing things that move our work forward. So think about theories, models, and frameworks, designs, measures that actually help you achieve that end goal of equitable implementation. And then the second one, theories, models, and frameworks you will hear can be super complex. So again, we are moving in this territory of highly academic thinking, and then we often try to get our partners to get excited about these. So we introduce them to these highly complex models, and we try them with them, and we try to have them understand the construct. I would say personally, and there might be different perspectives in the room, and we can discuss that, that's not necessary. Often these theories, models, and frameworks are only needed on the research side. And there is no need for your community partners or your clinical partners to interact with them. Or if you are going to have them interact with them, make them understandable to them. And again, it's not a matter of level of intelligence, it's just whether it matters to them. It does not matter to them. They care about improving outcomes, and they might not care about your very complex models. But despite of all of these things, theories, models, and frameworks, I do believe are very important to guide implementation science, not necessarily implementation. And so I would like to give you a little bit of a background on what is out there, what can you use, how do you use them, what resources you can use to help you integrate these, and then hopefully we'll have good discussion. So let me move on, let me see if I can, perfect. So this is the goal for the next hour and a half, or a little bit shorter now. I will talk about theories, models, and frameworks, what they are, how they can be useful for you. I already talked about how they can be not useful. And then how do you plan, select, combine, adopt, use, and assess implementation or DNI science theories, models, and frameworks with an equity consideration. And then finally, I also will build in to this presentation a web tool that we developed 10 years ago. It came up to its 10th anniversary in January this year. And so I would just share with you, and you might find it helpful. And I would also share other resources. So before I start, I just wanted to have some hand raising, or just yelling in. You're yelling out. Have you used the DNI theory, model, or framework before? How many of you have used? Okay, many of you have used some. Okay, and then could you share which ones have you used? Some of you, if you are willing to, feel free to just be very like a concert. CFAR, okay. RIEM, okay. Others? APIS. Okay, super, very good. That's helpful for me. And then how did you use it? What did you do with it? That might be a weird question, but it will become less weird once I talk. What did you do with it?
Evaluation plan.
Okay, okay. So implementation plan, various. Okay.
Strategy deployment.
So deploying strategies, you use the CFAR or one of the, or APIS to kind of guide you how to deploy, okay? Other ways? Okay, so to guide the qualitative data coding perhaps, and then presenting the results. Mm-hmm.
To be clear about the links between the different components.
Very nice.
Particular strategies.
Wonderful. So basically to create some kind of mechanistic understanding of what's going on and organizing that.
Develop the interview protocol.
To guide your interview protocol, what the components are, and then link it up. Very nice. Anything else? These are very good. This is pretty comprehensive, but we will see if there are some other ways that you can use them. And then what was most challenging about these experiments of using these theories, models, and frameworks, if anything? Perhaps it was not.
Way too many options.
Way too many options of choosing what framework is the right, okay?
Related to that, you think it's gonna be super simple and take 2 hours.
Mhm.
It doesn't.
I love that. There is a sense that, we are highly educated people. We have done much more complex things. Once I pick it, it will be easy to use it as well. And it's not. There is a learning curve. And I think that using it well, it's not trivial, unfortunately. So I hope that, we can kind of come to that conclusion at the end that you want to work with someone who has used that framework before. Great. Any other challenges?
Never quite the exact perfect.
I love that. So it's never quite the exact perfect fit. So do you ever have this inclination to create a new framework because these are not working for you? Don't do it. So I think that these are very, very typical, ordinary issues that we receive as part of consultations. In fact, if I had to say which are the most common questions we receive when we consult with individuals who are newer or intermediate even in implementation science, theories, models, and frameworks, how to choose them, how to use them. And so that is where we stop. And the problem is that that kind of blocks you from doing the next step, which is, moving forward with your research plan. You might wonder, if you have not yet looked into this, that, we talk about theories, models, and frameworks. Are they the same? Are they different? And of course, they are not the same. And especially those of you, many of you are trained in a traditional behavioral science context. You have very clear definitions of what a theory is and what a framework and a model might be. They have different abilities to predict. They have different abilities to organize. And so most of the work that D&I theories, models, and frameworks do is more on the model and framework end. We have a few theories, diffusion of innovations, I would say, and then a number of theories that we pull from other disciplines. But when you look at the traditional TMFs, in the web tool that I will share with you and elsewhere, most of them are falling under this models and frameworks category. At the end of the day, I have not found it helpful in my own work, just because I am not doing that in-depth theoretical work to distinguish these heavily. Practically, it's good to know that there is a difference, but practically, I am basically choosing something more based on the construct setups and how it has been used in the past and what kind of settings it's appropriate for, not so much deciding whether I need a theory, model, or a framework. Others might be approaching it differently, but again, in a very pragmatic way, which most of us will be acting on. It has not been kind of my main concern, is it a theory, is it a model, or a framework? But there is a distinguishing kind of definition set for you if you want to think about that. And again, remember, most of it is models and frameworks. And then why are they helpful? And many of you have already highlighted the key reasons why theories, models, and frameworks can be helpful. Generally, we hope that by using a theory, model, or framework, or a combination of those, we will be able to do some really nice, systematic, comprehensive work. And it doesn't mean that you have to include everything that is in the theory, model, or framework, but you should consider everything. And that's kind of what I hope it would achieve for you, that as you look at your theory, model, or framework, first of all, you can make it yours. So you can figure out what those constructs mean in the context of your study. And two, you will think through which of these components are feasible or critical in your current study. But then as you ignore the others, you do them in an intentional way. So you are going to say, in this stage, I am unable to study maintenance from REAIM, but I know that that's important. I'm not going to forget it. And future studies that I will do or others will do will get to that. You have to have a good justification why you ignore certain components. Same for, looking at CFAR, many of you mentioned that. CFAR is big. is gigantic. It has so many constructs. I don't know how many of you use CFAR 2.0 versus original CFAR, but it's good to have that comprehensiveness at a certain stage. And then certain data, whether it's from your prior studies or from your partners, clinical or community partners, will help you choose which are the most important or relevant constructs in this current study. And then you can justify why you are focusing on those, why you are acknowledging that others might be important, but you cannot study them in this particular context. So for those reasons, I think it's important. Many of you mentioned that sometimes you use it to organize findings. And I think it is actually helpful when you look at qualitative data or mixed methods data to use some of these constructs to present what you found. So there are many reasons why you would want to use them and others that I didn't read. But the last one I will mention, I believe, and I think that many of you will agree, that if you submit a D&I-focused grant proposal and you don't have a theory model or a framework identified and operationalized properly, you are not going to get funded. At this stage, we got to that point where that's an expectation. And I will emphasize, this is a D&I-focused submission. Many of you are going to submit to other types of submissions where it's not going to be an expectation, but anything that will go to a D&I study section, they will want to see a theory model or a framework. So at a minimum, from a pragmatic perspective, you want to have a well-operationalized theory model or framework in your proposal. But again, I hope that eventually you will fall in love with it and realize that it can be helpful as you made what is hard or challenging. There are too many of them, and that's very true. So I'm going to highlight the last number, 159. That is Lisa Streifler from Canada, looking at knowledge translation models, and they found 159. And most of you know that kind of knowledge translation is a rough equivalent of implementation science in the US. It's not exactly equivalent, but that's kind of the highest number I have seen published. But I would say that even with the 61 model by Rachel Tabak, which most of you are familiar with because that's kind of our etalon kind of paper that came out, it's too many. What to do and why are they, how they are different, etc. So I can tell you a little bit more about it and how to choose. But I will also say that, you know, you can get into the 159, or you can feel comfortable knowing the top 10 and then kind of working with them. And then if you get into a very unique project, dig into the more kind of nuanced versions. So there is the easy answer that, you know 10 and then kind of dig into the deep if needed. Alternatively, you can dig into the 159 and kind of explore them. So the question is, so which one should I use? And I am not going to give you that answer immediately, but I wanted to show you some of the main theories, models, and frameworks in case you are newer to this. Some of you did not raise your hand about using them before. Many of you will be familiar with diffusion of innovations. Is that true? Some of you, okay. So this one, first of all, the book is delightful. Everett Rogers was just a very good communication scientist who studied the diffusion of innovations, as he said in his 5th edition of his book, or 6th, I guess, 5th. Unfortunately, he passed away. But it basically looked at agricultural innovations. And many of you know about the hybrid corn seeds in Iowa, and studying why certain farmers adopted them and not. And then looking at other public health and non-public health issues like the different keyboards. In fact, there is another keyboard option that was available that was much more appropriate for kind of long-term work, but that didn't get picked up. And so he studied why this current keyboard setup is the one that we use. Also why people pick up or not pick up boiled water in South America, etc. Very good case studies. And based on that, he created some very interesting conclusions about the types of adopters. Many of you use this, even if you don't know diffusion of innovations. I call myself a laggard all the time in technology. Very true. And then, we have our innovators who we love, but then they are not the people who are being followed. Generally, innovators are risky. And so people look for more the early adopters. And so these are some interesting concepts and still very, very fresh. It's been a long time that it was published. I still recommend this theory very much for consideration. Lots of great content and ways of thinking about issues. This one is just a very quick mention. You cannot see the title. This is the Diffusion of Innovations for Service Organizations by Trisha Greenough. And Trisha is amazing. He used to be, I don't know how active he is on X or Twitter, and whether she moved somewhere else, but she's from the UK and just a very astute, delightful researcher. But this was for her dissertation work, and she has done some more work. It's very comprehensive. I have not seen this too many times used in a proposal, but this is one of the more comprehensive models, and it's an interesting way to look at these different constructs. And then this one, I'm just going to run through, sorry. Many of you are familiar with the Proctor Implementation Outcomes Framework. If you don't use REAM outcomes, you use Proctor outcomes. Fantastic, of course. And Enola Proctor and her work has been incredibly impactful in our field, including the distinction between implementation, service, and patient outcomes. It's coming from this work. And then, of course, the implementation outcomes, it's there in the middle. And I don't have that little circle, but implementation science truly happens in that how and implementation outcomes level. So as you think about our traditional work going from what to patient outcomes with the black box in the middle, implementation science is exploring the middle part. And then here is REAM. Yes, I am partial to REAM. I trained with Russ Glasgow, so it's hard to leave it behind. And there is no good reason. I mean, this worked for us so well. I have used this with community partners. This is one of those set of outcomes that actually resonate with other types of partners. Everyone wants to think about equitable reach. Everyone wants to think about whether we are reaching the people who are most in need. And it resonates with communities. It resonates with clinicians. Same with the idea of, adoption. We want to make sure that all settings and clinician types or community organizer types can use our intervention. So this has been one of those frameworks that I found very helpful in my work, and I continue helping evolve it and develop it. But again, there are many options. And I will speak a little bit, talking about equitable implementation, how REAM was designed with equity in mind. And we have a few new publications where we talk about equity and REAM and PRISM, which is, I believe, the next one. Yes. So how many of you have ever heard of PRISM? Oh, that's amazing. So PRISM came out in 2008 as a contextual extension of REAM, and then it went under. It was not cited, it was not used. And then about 6-7 years ago, we talked with Russ and Russ Glasgow, and I said, well, this is really, we have to pick it up. And so we started to kind of work with it a little bit more. Amazing boom of using PRISM, fortunately, and mostly because we acknowledge that REAM does not have contextual domains included. So what PRISM does, it adds multi-level contextual domains. And that's the original figure up there. I know that you cannot read it well. It's a little bit more simple than, EPIS or CFAR, so I like it for that reason. But it also puts more pressure on you to define what those different constructs mean. So when you talk about external environment, you have to operationalize it. And then the same with implementation and sustainability infrastructure. The most important message is that when you say I'm using PRISM, you already said you use REAM. So don't say I'm using PRISM and REAM. PRISM includes REAM. So that's kind of for proposals, just to be clear. But we have some other resources there that you can learn about. And this lower one will come back up when I talk about equity. Your friend CFAR, amazingly well-developed and very well-resourced framework, used very broadly, of course, in different settings. Laura Demscheder and team and many of the people in the room, I'm sure, contributed to the second version of it, which just came out fairly recently. And then, of course, in addition to CFAR 2.0, they also linked it to now outcomes. CFAR used to not have direct linkage to outcomes. It now has. So it can be a one-stop shop. You can pick it up and then kind of use it. Advantage, comprehensive, really well thought out, lots of resources. Disadvantage, very complex, lots of layers, lots to work through. So you kind of want to make sure that you understand how these different pieces work and what they mean. And then EPIS, some of you mentioned that, exploration, preparation, implementation, and sustainment framework. Greg Ahrens and team from UCSD developed it. Really neat as well, includes a number of different types of contextual factors. This is one of those frameworks that does not have direct outcomes included. So if you use EPIS and you want to measure outcomes, you will have to combine it with either Enola Proctor's implementation outcomes framework, or you will want to combine it with REAM or your own outcomes. But this is kind of, that's the only, I would say, backdraw. Never have been really a backdraw because people combine frameworks all the time. And I will mention that the unique piece of EPIS that is different perhaps from CFAR or PRISM are the bridging factors and the innovation factors. And there are some recent wonderful publications talking about, including Rebecca Lesnick-Hall and others, talking about how to operationalize those. That's kind of my kind of sore point. I'm not really efficient in that yet. So looking at those publications is a great idea. And then we will talk about equity, but there are frameworks that are more specialized. So the health equity implementation framework, how many of you have used it before or heard about it? Eva Woodward's, yes. And there is a newer version of this, of course, that is more operationalized. I think this is the original. This is a very focused implementation health equity framework. So if you are, that's your kind of niche, that's what you are trying to do, then you would pick a health equity framework. I will talk about how you can also use traditional frameworks like EPIS, CFAR, REAM, PRISM, and have a health equity angle, but you could choose one that is specifically designed for this. There are other frameworks, they are different, they are very unique to a topic, like, you know, health equity is still a little bit broad, but I am Adopt. How many of you have heard about that? So this one is specifically focused on guiding adaptations. So if you are going to do a study where the first aim is adopting an intervention to a specific context and population, I Am Adopt provides you with a step-by-step approach to get to that place. And it can be a really good framework to include guiding your specific aim one, for example. And again, I'm not getting into the details. I don't know if you have, I don't think there's an adaptation topic in this session, but that's my other love project. And then another one, FRAME. How many of you know about FRAME? Few. So FRAME is designed to document adaptations in your study. So you would not use FRAME to guide your full study unless the full study is about documenting adaptations, but you would combine it with other framework to document adaptations systematically. So this is the Sturman and others. And then there is a FRAME IS, which is an implementation science strategy focused version. So these are very specialized, please.
So would you use something like FRAME with adapted, the adapted model that Gina Wingood and her
Yep.
husband developed? Okay.
Yes, so let me kind of bring this up to the full group. I showed you I Am Adopt. This is one of 17 frameworks that were identified by Escoffrey and colleagues that are guiding adaptations. Adapted is another one like that. You could combine the use of that with FRAME, and FRAME would help you document the adaptations you made before implementation. But FRAME was also designed to document adaptations during implementation. So this one can be a really, even if you are not doing adaptations as their first step, FRAME could be a nice thing that you include because we know that there will be adaptations, whether we like it or not. And so this could be that way, or you can combine it together. Very good. Okay, so I still didn't give you how to choose, right? We are still just getting more and more confused and overwhelmed. Me too, at this point. I love this. This was a physician colleague in Colorado who shared this. And I was like, oh, I have a lot of physicians in my family, so I really related to this, and I'm PharmD. So the young physician starts life with 20 drugs for each disease, and the old physician ends life with 1 drug for 20 disease. And I think that that's kind of what happens to many of us. I don't say that this is the right thing, but that's what naturally happens, that you start with a very open mind and you dig, and the 159 is in your mind. Like, I have 159 to choose from. And then as you start to use them, first of all, you realize that it takes some effort to use them. It's not trivial. You have to learn how to use them. So learning every single one of them, it doesn't seem to make a lot of sense, especially when you realize that the added value will be low, because they really interchangeable. So if you want to ask me, you know, I mentioned 3 frameworks that are very contextual: PRISM, EPIS, and CFAR. I have created a crosswalk, and I am not sharing because I have to validate it with the developers of CFAR and EPIS. I can crosswalk the three. So you could basically use any three of them. Why would you choose one or the other? Well, first of all, you would have expertise on your team in one or the other. So that's usually a good thing, again, because of the reason that it takes a moment to realize what they mean by certain constructs. Plus, in a proposal, it will look good that you have someone on the team who knows how to use CFAR, EPIS, or PRISM. Second reason you might use them, because it has been used in this given context in prior studies, and so you want to build the literature and you want to say, you know, PRISM has been used in this context. I would like to apply it in this slightly different context or population, and I want to look at it. And then in some ways, I talked about nuance differences. So I talked about how, you know, PRISM includes re-aim and context. So if you want to have re-aim outcomes, it's easy to use PRISM because it's already including everything. Re-aim and PRISM includes a, you know, health equity focus. So you might choose that. EPIS, it has those bridging factors and innovation factors. You might really want to hone in on that. CFAR, really, really broad. You want to consider a lot of different determinants. So those are some questions you might ask, but generally, I think the main thing is that you choose a model that seems to kind of intuitively fit with your project. You have access to expertise to use that model. And then at the end of the day, you will have to do some adaptations. And someone mentioned it never seems to fit exactly. So I will talk about that. If you want to use another kind of classification of why we would choose something, this is Per Nielsen's work. Many of you are familiar with this classification of theories, models, and frameworks, thinking about whether these are served for more of a process model, determinant framework, classic theories, implementation, and evaluation frameworks. Many of the ones I mentioned can combine those functions. So for example, Per classified re-aim as a purely evaluative framework. That's not the case. Re-aim alone has been used for planning and implementation guidance. So I would say that this is a good starting point, but don't always stop there. Think about it, because some frameworks can do a little bit more than where they were initially classified. That's the, you know, kind of the negative about classification. The positive is it makes it more manageable. Negative, it might take out some nuances. But this is a very nice starting point as well. And then this is my very good colleague and friend, Tina Stutz, put this together also to ask some questions about your needs and then kind of link it with the types of frameworks you need and the examples that are provided. This is kind of mapping onto Per Nielsen's thinking and goes beyond it a little bit. So again, you can think about, you know, very specific outcome focus and going all the way down to focusing on very specific topics such as adaptations, equity, etc. Feel free to, again, review these, think about these, and then I'm happy to answer additional questions. But of course, as I mentioned before, and many of you are very familiar with this slide, this has been circulating, has been attributed to Trisha Greenall, who I mentioned, and others in the field, but theories are like toothbrushes. Everyone has one and no one wants to use anyone else's. Do not create a new theory model or a framework. Trust me, if you contact me, I will make one of them work for you. But it's a lot of work. That's the other piece that, you know, Steve, you mentioned that it's not easy. It's not easy to create a new framework. It takes a lot of work and then validating it and whatever not. So there is always a way to make these existing ones work, I am confident. And I would say that there is one more way to personalize them, and that's going to be through using a logic model and combine the two, because that can really give that special flavor of your study. I am going to, some slides I'm going to go a little bit faster because I want to have discussion instead of me presenting, but I want to make them available to you. So these are some additional questions. These came from NIH colleagues and other publications of, you know, what kind of things can you still consider in addition to what I already said when you choose frameworks? And then I would say that this is a good one for cross-cutting kind of decisions. Is most of the D&I theories, models, and frameworks will acknowledge that we are working in a messy multi-level context. So find a framework that can deal with that. Again, it's contextual, it's intuitively seeming to fit. Face value does matter. And then ideally there are measures available. And I will speak to this in a moment, but measures are very tricky in implementation science. We have very few. When we have them and they are validated, they are long. And so that's the tricky part, that, you know, finding the right assessment instruments. And then, of course, it can be good if it has already been tested with the population topic that you are working on, or if you want to be innovative, it has not been tested, and you will highlight it as an innovation in your grant, because you can talk about how you are now going to use EPIs in a very new context it has never been used in. And then this is just, again, some of these websites where you can learn more about these frameworks. But at the end of the day, and that's kind of going back to your point, all models are wrong, but some are useful, and you are really looking for that model that will be useful for your study, your population, not to make things harder. And I think that that can be a pretty good kind of measure of, you know, is it a good one or not? So I mentioned earlier that we developed the web tool about 10 years ago, and we have been, you know, kind of improving it over time, went through at least 3 or 4 iterations. So I want to encourage you all that just kind of type it into your browser if you can. It's on the bottom there. Yes, we snatched that domain name. We were very proud of ourselves, and we are holding on to it. We have, I think, the net version of it as well. But anyways, so this web tool is free to the public, and it's not perfect by any means, but it was based on that TABEC article, so the initial set of variables. And then over time, we kind of realized we need to expand and get better. But you can go in here and then go through these different steps. And I will highlight a few things from each step today, but I'm not going to kind of read everything because you can find it here. This is guidance now around how to plan a study before you even pick a DNI theory model or framework, how to select a framework, combine multiple frameworks, adopt them, and then use them, and finally assess them. And so the key piece that I will highlight here, and I will go into this, is the use. People got really good about knowing that they need to pick a DNI theory model or a framework. They are not as great about applying them. So we still find some studies where the framework shows up at the beginning, and I don't see it again. Well, this is becoming less and less frequent, but I also see it show up again inappropriately. So the point is where we now have to learn. The trick is people pick the framework, then you have to operationalize that. And that's where I think people struggle. It takes up space. Sometimes it's not efficiently done, etc. So I will show you a couple of examples where this was done, I thought, relatively well. One of them is excellent, Dr. Kanamori's example, and the other one is mine, so relatively well goes to that. So in terms of planning, I just want to encourage all of you, and this is relatively new to me. The past few years, I became obsessed with logic models, and then JD came out with his implementation research logic model, and that's even better. But this is our attempt for an implementation logic model before JD's was published, talking a little bit about the different components of the implementation science studies. And you can find actually a template and complete it on this web tool. But the idea is, it doesn't even matter. And I am not using the logic model terminology in the traditional sense. It's a visual of what you are trying to achieve. And so we have so many stories from colleagues who were sitting in a bar, restaurant, wherever, or on a hike. And they took, you know, the cocktail napkin comes, that's why the bar. But, you know, you take a piece of paper and you start to talk with people, and what you will do comes out and you draw it. And perhaps that's the best model you have, because that is informed by your partners. That is really pragmatic. And then the theory model and framework can overlay on that, but never underestimate the value of easy drawings of ideas together. And I think that that's, you know, a logic model can be such thing for someone who is worried about a blank page. So you can have something to structure around, but this can be very powerful. And this is JD's that we will, you know, you have already seen, and we will discuss more this week. You will get a really great guidance from him how to use it. Their website is incredible. Yes, it's there. You can go there. There are different variations of this. So I will leave it up to him to kind of share it with you. This is a version of that. Some of our colleagues used the implementation research logic model. This is not version 1, it's version 21. So don't get scared, but this was part of their proposal as required by EHE. But how beautiful it is, how powerful. And it does include a theory model and framework. You can see that on the left side, the determinants are organized actually by the PRISM context domains. And the outcomes are the REAM outcomes. So they kind of, what is it? 2 birds, 1 stone. So it's basically, they integrated the DNI TMF in the logic model. So it has that academic spin, but it has this like nice, understandable structure, at least, to most of us here. So in terms of selecting, I already mentioned that, there are some general rules I would use, and there are top 10 frameworks, etc. But if you want to dig deeper, then you can actually go into this web tool and use some criteria on the left that will screen out the ones that are most appropriate for you, including certain constructs. So if you want certain constructs to be in your framework, you can use those. So that could be one way for you to identify them. And then, in this case, we identified EPIs through a search, and then you can kind of go in and get some information about EPIs, including some characteristics of website linkage, and then examples of how to use it. Another tool that is a little bit similar that helps you compare. So our tool can compare models, but this was created by Sarah Birkin and colleagues. So you can also check out the TCAST. Again, it is to compare different theories, models, and frameworks for your work. You can combine the two tools. And then there are a number of publications here that I wanted to point out. We constantly update our database, but we don't have everything in there. We have currently about 113 of the theories, models, and frameworks. Here are some other publications where they specifically looked at subtopics. So you can see one around community engagement and implementation science, and what theories, models, and frameworks are being used for that. There is one about de-implementation. How many of you are familiar with the concept of de-implementation? This idea of getting things that don't work out of practice. By some, it's believed to be harder than implementing new things. So there are certain frameworks, and this is just one. There were actually 3 reviews looking for frameworks, so you might want to look at that. And then I just tracked this one. It's a 2024 recent publication about theories, models, and frameworks used in rural settings. So it's kind of, that's another way for you. Is like, I am really interested in this sub area. There are some specialized reviews now, and we are trying to keep up, but we are not, on the same day kind of updating the database. So look at those as well. In terms of combining, we have guidance on the web tool. I'm not going to dig, but I would just say we often combine theories, models, and frameworks. I already mentioned examples. EPIs, it doesn't have outcomes. Combine it with, Proctor outcomes or REAM. You combine a general framework like CFAR with frame because you want to really focus in on adaptations. You combine a general framework like EPIs and add the sustainment tool or framework by Doug Luke and colleagues. These are all very valid things, and you can think about them. What I would warn you against is to combine too many frameworks. When I see more than 2, I start to get anxious. The frame, I don't even introduce it as a framework. I just talk about it as a way of documenting things. It takes a lot of space in your proposal to explain each framework and then explain why you are combining them and how you are going to do that. And so only do that if there is a very good reason. And so I would say that 2 is usually good. This is a rule of thumb. There are reasons where you would use even 5, I am sure. But generally, keep that in mind, that this is not a time for you to be very innovative, to have, I am combining 6 different frameworks. It's just not going to work. And the reviewers most likely get confused very quickly. And then it's not good when the reviewer is confused or angry. So there are some examples on the website. There is also an example with policy. So sometimes, policy needs to be dig into. So you have a general framework, but then you have a policy framework to expand on it, etc. You can combine a health equity framework to speak to the topic of this week with a general framework to help you get really into the health equity field. Lots of different options. And I would just leave it at that. I would say that I mentioned already, you want to be very clear why you are combining if you are writing a proposal, because that will be requested by your reviewers. And again, this is all what you see here is in the web tool. So all of these you can find as guidance. And then there are some examples as well of combining frameworks. Some of these become less relevant because now CFAR has its outcomes available. So some people, but some colleagues still prefer, using their Proctor outcomes or their REAIM. And so they combine CFAR 2.0 with that. But there are some other examples. Okay, adapting. This is speaking to the idea it's never perfect. Yes, you are going to make some changes to frameworks. And what kind of change is okay? I cannot give you a very, kind of cut and dry guidance. But generally, you want to think as you are starting to take apart the constructs and kind of putting in many new constructs, you are kind of stepping away from the fidelity of the framework. Many of these models and frameworks are not theories, as I mentioned. So it's not like you are changing the predictive ability of the framework. And more often, what happens, people end up not using all the constructs. That's a very common adaptation. You want to justify why you are not using, but that's okay. And then the other piece is when you are using certain terminology. So let's say that, CFAR has a certain internal inner setting kind of construct, but you want to name it differently because it's more appropriate for your population or setting. Those are all okay. And in fact, they are very helpful. I will show you a couple of examples where PRISM was adopted to the local population. There is some guidance on our website about these adaptations. But again, this is a very difficult area because it's not like if I take out one construct now, it's all ruined. But then if you start to add a lot of more things, et cetera, you wonder, is this the same framework? So the changes need to be changes that will be meaningful for your study and will help, your partners, if you are sharing with them, or your reviewers understand how this works in your case. And then the use. So this is, again, the main issue. I would just say that the theory model and framework is not just showing up at the beginning and then disappearing. You want to introduce it. Often we have a section, theoretical framework, and then you want to introduce it. You want to explain why you are using it. It doesn't have to be a full paragraph, 2 sentences, but then it has to appear again. It has to appear in how what kind of methods are you using, what data you collect, how you organize the data collection, how do you organize the data analysis, the interpretation of the findings, and the presentation. And it just will nicely flow through. And some pieces will be more emphasized in certain studies than others, but I want to see this everywhere. And I want to see that this is not forced, that you are just, I have to now put in these constructs as well. No, it has to be integral. It has to feel that it's helping you. Thank you. And then I am going to go a little bit further because that perhaps is the main component. I'm going to show you 2 examples of using of theories, models, and frameworks. The first one is, again, one of our studies that is funded through NIH, uses a smart design to test some strategies to improve COVID-19 vaccine uptake plus preventive behavior uptake in FQHC. So it has this health equity component. And so you can see that in our case, we decided not to call out the theory, model, or framework in the aim specifically, but we are referencing it by talking about multi-level context and the examples, and then also the outcomes, the REAIM outcomes. So it is not always that you have to, the specific aims page is short. So the theoretical framework is introduced or not, but most of the time you end up just basically mentioning the different constructs. And then in the approach, we have a section where we introduce PRISM and why we think it's going to be helpful. And then we go on and we have a visual, and you can see that PRISM shows up very prominently, guiding what the study will do. So you can see the determinants or contextual outcomes, and then the PRISM outcomes or REAIM outcomes there. And then we go on and we get to the measures and we link the measures to the different constructs. And then on the right side, you can see how the qualitative analysis and the mixed methods integration is bringing back PRISM. So it's not always very long, but it's constantly kind of bringing back how I'm going to use this. And the other one that you will hear more about from Dr. Kanamori and team later, but this is his study and how, and this is from his presentation at the EHE meeting when we had a specific DNI TMF session. So in their case, the study aims did include the call out for REAM and CFAR specifically. So they are not kind of keeping it secret, they are going right in. And then if you look at their logic model, which I love, by the way, this is kind of a beautiful use of a logic model. You can see how the CFAR context domains show up on the determinant end, describing what they have measured in prior studies, in fact. And on the right, you can see the REAM outcomes showing up. So really clearly identifying how this is going to be integrated. And then again, this is about their measures and how they are going to assess some of these. I will skip this one. This is just a way that the PRISM has been adopted to different studies to show what things have been changed. And then there are some other resources that can help you integrate your frameworks into your study. The last one is assess, and I will be very brief. Assess is a very small portion of our web tool now, but we are working on a brand new version, and you get a sneak peek here. We are going to actually have a direct linkage as a repository as part of Assess, and it's going to be ready for reviewing by the end of summer, and then hopefully by the end of the year completely up and running. This is an NIH-funded activity that we are doing with a number of experts around the country, and you will be able to screen out actual measures or assessment instruments, including qualitative instruments, through the tool. So you can go from, logic model to actually choosing of measures. And if you have any questions about this, I'm happy to talk about it separately. And then finally, I would say that health equity is at the center of our thinking as well. We do have a separate section on health equity. And I will just very briefly show you that we have some guidance on how to think about incorporating health equity in your use of TMFs. There are some examples of how health equity has been used alongside with TMFs in implementation science on this section, and a number of publications that started to think about this idea of health equity lens and DNI TMFs, including the PRISM paper, including Eva Woodward's paper that I already mentioned, and a number of other publications that talk about health equity focus and implementation science. So you can really access these. And in my last slide, I will say that this is a new tool. I serve actually as an external assessor on Lisa's dissertation defense, which is happening soon. She developed a tool called Find TMF. And it's kind of doing something similar than ours. I'm still figuring out how it's different. And I couldn't find it online available, so I'm going to email her. But this publication speaks to this other tool, so I wanted you to be aware of it. Okay. I didn't leave enough time for questions, but we have a few minutes, I think. Plenty. Oh, wonderful. Okay, super. Oh, perfect. So this was just for the presentation. So let me just go back and see whether you have any questions. I will leave this up. These are just some take-home messages that we have already discussed. Any questions about just the general content before we get into more application discussions?
I have a question, just a comment. I didn't know that you were the creator of that website, so I just wanted to thank you.
Oh.
Because it saved me when I was trying to figure out which tool, because there's so many theories, models, and frameworks. I was like, okay, I'm overwhelmed, and you want me to pull together an application for K, like, just not happening. So I just wanted to thank you because you really did save me and help me figure out which ones to use for my K.
Thank you so much. I'm so glad that it was helpful. Again, it's not perfect, but it's something that you can kind of get started with. So thank you.
Yeah, that was an excellent presentation. And finally, I read your work and finally get to actually meet you in person.
Oh, thank you.
I do implementation science research too in low resource settings, thinking about Colombia, my work in Colombia, thinking about my work in Philadelphia, North Philly, Kensington, low resource settings. And even thinking about CFAR and inner setting, outer settings, sometimes there's not the inner setting is not there, right? Or
Yes.
the outer setting is not there. So I was wondering if you could talk a little more about your experience adapting these frameworks to in low resource settings and in community-based organizations that don't have a 340B program or a well-staffed that we cannot really capture regain and CFAR inner and outer setting.
Yeah. Thank you so much. That's such an important question. And again, with the theme of this week, we have to keep going back to this because many of these frameworks were still designed in high resource setting, you know, clinical, etc. context. So yes, very important. So I would like to encourage you to look at Meredith Fort's work. She actually in South America, she used PRISM specifically, but worked with the local partners to make it work for their, and actually they did a translation of PRISM to Spanish. And so they really kind of try to dig in what it means and how to operationalize it. And not necessarily to encourage you to use PRISM, but the process that she went through. I have not gone through, well, I have worked with a few colleagues who have done especially HIV work in Africa, thinking about this. The other person is Greg Ahrens, the EPIS work, and they have used EPIS in the kind of many different low resource settings and contexts. And so they thought this through. Most of the time, what it takes is really, you know, you bring your concepts, but then you work with the local partners. And in terms of, you know, certain things not existing, that's also an indication, that's also a finding, right? That certain areas are completely lacking. And that's actually Meredith shared with me that certain components are just not there. And that's an important finding to report, that what is missing is complete implementation and sustainability infrastructure, non-existent, or external environment, the multi-level nature of it, and who is playing, who is not playing. So the process of using it, again, going back to your point of this is not easy or trivial, is that it will take a moment to make this work. But I think the process has its own value. It's not just LAR, you know, academic endeavor, but it actually can create understanding and even publishing something about how you made that framework apply or not apply in that context. But again, the main methodology I recommend is partner engaged, dialogue iteratively, and then as needed language translations. Yeah. Yes.
Hi, I'm curious to ask about what your thoughts are regarding de-implementation and de-implementation science, I guess, and whether that's a completely separate focus area or if it should be in considerations when you're thinking about implementation science, right? I thought it was interesting that you said that we don't need more models, right? And what I like about adaptation science is that you're also looking at what's existing and thinking, do we need something else or can we use what we have and adapt it to a new context? So I also think about thinking about implementation simultaneously with de-implementation, thinking, do we need to add this intervention? Or would our money and resources be better spent thinking about what's not working and perhaps using science and these frameworks to think what needs to be de-implemented? And when there's that gap missing, how can that we think about implementation? So I know I just rambled, but what are your thoughts on that and in terms of that being a developing field? Because as you showed us, there was only like several scoping reviews and it seems like it's developing, but what's missing or how can it catch up in how implementation science has developed?
Thank you so much. Super question. I would say that they have to coexist. In fact, some researchers say that the implementation can be successful if you substitute instead of take away. Especially, you know, most of the work in the implementation has been done in the clinical context, some public health kind of implications, of course, with, you know, the drug related interventions that have been funded for years federally and they didn't work. But most of it is looked at in the clinical setting. And in fact, you have, you know, websites that talk about what practices are evidence-based and what not. And the complication is that there is, again, it's a multi-level complex thing where the patient will not get now what they are used to getting. I don't know how many of you are MDs here and dealing with the issue of not prescribing antibiotics My husband is an MD, and that's a common, he does telemed, and I am just listening. This is still going on. Patients still ask for antibiotics, and when you say it's not evidence-based, they feel shortchanged. So that's just a very simple example because we know about that, but there are a whole area of clinical activities that we know actually will make things worse. And so implementation could mean that you implement some sort of education in conjunction with taking away the actual practice, etc. There are some really good publications on this. It is amazing that we have this many frameworks actually just focusing on the implementation. I would say that some people believe that certain strategies like we didn't talk about it yet, but the ERIC strategies that Byron Powell put out there, if someone might be talking about it, I didn't check. There are 73 of them, and you can kind of think about them. They could work for the implementation. Others think that you have to have unique strategies for the implementation. And so that's an area where you could really dig in. And I believe that the most recent PAR for the DNI call for NIH includes the implementation as a priority area, in addition to dissemination, which is another research area that is underdeveloped. So you might want to think about how to kind of explore that. Did it answer mostly your question, or okay, thank you. Okay, super.
Since you mentioned dissemination, and also since you're the first speaker, could you just clarify the difference between implementation science and dissemination science?
Sure. Absolutely. Not an easy one, right? It seems like an easy. So I would say that, again, dissemination and implementation research coexist, but they are not the same. Dissemination research is focused on how to get evidence to the hands of the individuals that it's meant for. And so you are studying channels and packaging methods that you use to put that evidence in a way that it will be actually received by the end users. It has a kind of the communication research component to it. It is studying the speed of getting evidence to people. And then it kind of stops there. And then implementation science almost picks up there and looks at how you can improve the uptake and ongoing sustained implementation of interventions. So again, the two cannot exist without each other. Some people think first implementation happens and then we disseminate. Then, people talk about scaling, which can be also thought of as a form of kind of dissemination. Other people think first you have to disseminate something so that it can be implemented. But the difference between the two is are you focused on the getting things to the end users, and are you focused on strategies that will improve that, versus focusing on the uptake and the implementation and the barriers to those. And so the part that has not been studied as much, and we don't have very good measures, although Anna Baumann published a paper on dissemination research, so I recommend that one, is dissemination outcomes specifically, and then also studying strategies that improve the reception, the receipt of the evidence by the priority users of the evidence. Yes.
This is more of a commentary versus a question.
Please.
As I think about these theories, models, and frameworks for health equity, I think of two things that are missing, like blatantly missing.
Yes.
One is trust, right? This idea of trust between us as implementers or academics and our community partners. I think trust is like a fundamental component that allows us to implement, allows implementation to occur and sustainment of implementation. And so I'd like to hear what you think of trust as an implementation determinant, building trust as an implementation strategy, and also trust as an implementation outcome. The second thing, you brought up speed, right? We're constantly talking about implementation sciences, 17 years to bring, from, basic science to clinical practice. But inherently, the urgency will create health disparities because we understand that there's mistrust in communities when it comes to innovations or new interventions. I think about this with long-acting injectables that are coming down the pipeline, COVID-19 vaccines, huge scientific breakthrough, extreme health disparities when it came to implementation. And so I'd love to hear what you think around speed, like not slow implementation, but maybe like deliberate implementation as a concept of an outcome, because we're always focused on translational pipeline. And when you think of translation, you think of speed. We have to do it quickly and urgency when it comes to these things. So I'd love to just hear your your thoughts on this.
Thank you so much. I have to go back to CFAR 2.0 to see because they have so many things going on, whether trust is included in some explicit way. But I would say, I would argue that we all should think about trust being some form of construct in our work. And, you mentioned this idea of, I would say moving at the speed of trust, right? As a concept, which I love. And I think we cannot move faster. So I very much agree with you. What it takes me to is perhaps a little bit unorthodox or not in the line of what is being mostly funded. And I am sure that Alex is going to speak to that quite a bit. The idea of creating things, co-creating things, using a user-centered or human-centered design approach to engage your partners throughout the process. And that would mean that you are not using a traditional pipeline method like the figure we showed initially, but instead you co-create in cycles sometimes with the partners. And I think that that will take care of your trust. That will also take care of speed, because if you are doing, PDSA cycles or small cycles of testing, that's faster than a 5-year R01. But it takes away that same type of rigor that we are expecting right now from funding agencies. And so what I would like to reflect on is, are our designs in the way of us increasing speed and increasing trust? Because the way that these traditional studies are designed, it's not to increase trust. There is a lot of mystery there, double-blinded. I mean, really, the community will be super excited to know that they have no idea what's going on. And even the people who they trusted, the implementers, have no idea what's going on. So I am being extreme here, and I apologize if this is getting too out there, but I just am saying that I think that certain designs, newer designs, will help us take care of both of those issues that you mentioned. I want to highlight one more thing that you said. I think it's very important. You said trust as an outcome, trust as a strategy, and trust as a kind of determinant, right? Yes. And so I think that that is fantastic. And I would love to see that. I heard this same idea for health equity, actually. And again, because of the topic of the workshop, I would say April O from NCI presented this as such, that health equity could be thought of as a determinant, could be thought of as a strategy and an outcome. So I really love that. And I really love to think about whether it's trust or health equity or other things. How can we build these in not just as one thing, but multiple things? And it will determine how you study and what you study, but I love that. So that's kind of, and then I wanted to actually, I remember what I wanted to say about the implementation question. The idea of co-creation, I think, addresses some of those issues as well, whether we want to take out something or just fix it in situ. And I think that, again, the idea of human-centered design and the idea of working with your partners to improve fit instead of creating a new intervention comes to that. Yeah.
I took notes that we can come back to this tomorrow.
Super. That's great, Alex. Thank you so much. Yeah. Please.
Just kind of feed up his question, wouldn't the trust building be a part of community engagement strategies? Because when I hear that, I think of community, either like on the continuum, I could think of community engaged versus community partner research.
Yes.
Right, and community led. So I would think that as part of that, which if we're looking at equity, like there's no way you can make sure that something's equitable if they don't have a voice in what it is you're creating. Like that's like the whole purpose. Otherwise, like why are we doing what we're doing?
I love that. I would say that what I hear here is that perhaps one operationalization of community engagement is trust building. I'm kind of thinking that meaningful community engagement is the big umbrella. But when I hear that, I am still perplexed. What do I do? What does it mean? And so one way is like intentional trust building, but I don't know exactly what that means either. I'm trying to dig down, but I think that these are all interconnected. And I would definitely say the ERIC strategies are not very rich in engagement, community engagement components. So that's something to think about, Alex.
I just wanted to add, because I am seeing some confusion on your face. And so tell me if I'm wrong, but I think maybe the reason that this isn't adding up is like my experience of implementation science is that it's not inherently community engaged. And you might think that it is.
Mine is, that's why.
Yeah.
Yeah.
People talk the talk, but you can meet plenty of people who do implementation science in this very linear, like we have the research evidence,
we know what's best for the community, we're gonna go out and like convince them to adopt it. Right, which is not a community engaged model at all, but you could still check all the boxes
Yep.
of like typical implementation science, taking that approach.
Yep.
So the fact that your starting place is community engagement is a strength, and that's great, and that's not every implementation researcher's starting place. So like, don't give us that credit, is what I'm saying. Don't assume that. You can't assume that, because we're, you know, implementation researchers are still researchers, and they're out here academic all over
Yep.
things.
And they become more and more academic.
Sorry
Okay.
to burst your bubble.
So a couple of things. Is this still related to the engagement component or something different?
Something different.
Okay, so I have one person there and you. Okay, thank you so much. I love this, and let's talk more about this in the coming days and come up but I love this clarification that I don't, you know, I'm coming from more of a clinical training, so I know where we are in the double-blind, you know, study design. So it's absolutely beautiful.
And what I was saying is not apply to Borsika at all. I'm just saying there's people out here.
No, I think that it's very much a paradigm shift for implementation scientists. Even. Yeah.
Just a pragmatic question about grant proposals with TMFs. So no, depending on the institute, the RFA that you're submitting to, we don't know how expert reviewers will be in DNI and how non-expert people will be. So I'm curious how you balance integrating and writing about TMFs in your grant proposals, knowing that you could have this very mixed review panel.
Yeah. So first of all, I would think about whether the proposal needs that TMF. And so if it goes to a DNI focus section, there's no question. But if it goes to a non, then you want to make sure that this is adding to the proposal because it's going to confuse some people. And you want to be, in that case, take that little extra time, and space, not necessarily saying that you put 2 or 3 more paragraphs, but provide a little bit more explanation why DNI TMFs are helpful and how you are thinking this will help your proposal. Sometimes 2 or 3 sentences can make the difference. And again, I would really make sure that this is improving the understandability of the proposal if it's not a DNI focused session. And, you know, a logic model, again, generally resonates with most reviewers. If you hide the DNI TMF within, as I showed you, then you kind of take care of both things. You have your DNI TMF, but you are still carrying your reviewers with you because the logic model will help them. So,
Can I just add to your
Yes.
answer? Because there's really 2 big HIV study sections, and I think, you know, most people here are doing HIV research because that's what the focus is. You know, HIVI and PFAR are the 2 committees, and typically there's like a couple implementation science people, but not necessarily like this level person. There might be, but I think like I think you do have to explain enough that you're satisfying someone like this, as well as like someone like me who like knows a little bit, as well as unfortunately someone who's like an HIV researcher who knows like the public health science or the, you know, so you kind of have to do all of that, I think, for the HIV committee.
yeah. And I would say that you want someone on your, so for me, it's very easy for you to help with that. I'm just saying, and many of my colleagues will be very well suited. So when you do it the first time, work with someone who can help review it and add enough nuance for you. But I really appreciate you bringing up that you always have to write to your reviewers. So yeah, and that's not always obvious. Please.
Hi, I think my question is probably about review too. It goes back to something you said in your preamble, that not every treatment or not every product should be subjected to an implementation science test. And there are some things that are just not appropriate. And some things that we know are not going to work. And it strikes me that one of the ways of thinking about implementation science is that it uses scientific methodology to identify the conditions under which a particular treatment or intervention will work.
Mm-hmm.
And to have to put ourselves in a position to say, with any given proposal, this isn't going to work in this setting. Because I think a lot of us would like to think that that's an empirical question with an empirical answer.
Mm-hmm.
And you seem to be suggesting that we kind of need a meta theory to guide just a general evaluation of what we're going to clear for implementation science investigation. I don't disagree with what you say. I think you're absolutely right. A yoga-based intervention to treat PTSD in
Mm-hmm.
conflict, resource-limited
Yep.
setting is not going to be an appropriate intervention. We don't need a science to tell us that. Perhaps maybe some people would disagree with me,
Mm-hmm.
but it seems like we need some sort of decision tools to be able to say whether or not this is a suitable intervention for this setting is a good question for our science. And whether or not this is a suitable intervention for this setting, well, we can say a priori that it isn't.
Yeah, this is a tricky question that you pose here because we have a few measures where, readiness, system readiness measures that would evaluate whether there is a match or a no match from the beginning. And you could do that, right? You could engage people. There is ORCA and other measures that we've been designed to assess whether there is a likelihood that this intervention will be. And I would say I would use mixed methods in every case. I think it's generally my question is under what circumstances for whom will this work and in what form? And I have a hard time deciding without this specific intervention, what would be the go, no go, decision point at the beginning. But I would talk with my partners, and if they generally seem to see that this is in line with what they like to do, and we have prior evidence from other settings, I have a hard time justifying that we would not at least try and make adaptations to make it appropriate. And I think the adaptations is the secret to improve fit. Now, if there are no resources that are needed, so that's one thing that we have done before. We said, let's see what are the minimum resources needed for this to work. And those are not available in the setting. And there is no way to, circumvent that or kind of replace it. I would say that then it's a clear indication that we should not try because there will be no implementation. But beyond that, if it's the question of how well it will fit, how much, if we give ourselves some flexibility in how we do things, then I would try it and that's where I come in, but I like to iteratively improve the intervention. But I think that the no-go would be for me that there is no way to get the minimum resources needed. Yeah. I think we are at time. So I am very happy to talk with any of you after. This was wonderful. Thank you for being so engaged, and I will look forward to our coming sessions. Thank you.
Thank you so much. Okay, so we have a quick 15-minute break. The restrooms are right around the corner, and there's still some coffee and snacks out there. And just to remind